All right, thanks for signing on, guys. So this is first lecture core, unless you guys have already watched the one by Dr. Wu. But this year we kind of alternate core in arthroplasty, hip and knee. So this year is hip topics, and so this is actually 2 lectures together. So we'll see how long. I don't think it'll take a full 2 hours, but you guys have to take off or whatever. That's fine. Just it'll get posted on Zoom afterwards. Or on Box afterwards. So the first half we'll talk about patient evaluation, imaging, biomechanics, and then we'll go over some total hip principles, and then specifically AVN and DDH in a little bit more detail. So feel free to chime in and ask questions if you have any at any point during this. So first off, and you know, I feel like we've gone over a lot of this already in kind of the arthroplasty lectures that we've been doing that a lot more people have been in than normal. So if I'm flying through stuff, it's because we've probably just covered it recently. But all the information is here, and then it's kind of loosely based on the AAOS book, so you can always refer to that. First off, history and physical for a total hip. Pretty straightforward. These are the same things as any orthopedic problem. So hip patient evaluation, you want to know where it is, what's the severity of pain, what have they tried, activity level and goals, and then desire for surgery. So the last 2 are kind of the most important points in an arthroplasty clinic anyway, is trying to figure out what is their actual functional level, what is their goal for a functional level, and then do they actually want surgery or not? Because getting to that pretty early can help guide your discussion a little bit. If someone is very gung-ho anti-surgery, that's going to be a lot different conversation than someone who's there, tried everything, and just wants to go straight for the surgery and save you a lot of time. Let's see. In terms of figuring out what hip pain is, you know, there's definitely differences in the hip is probably one of the more complicated places in terms of people call their hip pretty much anything in the area. So the differential can be kind of broad at first. So really important to kind of narrow these things down and really tease out where are they having the pain, when are they having the pain, what's the quality of the pain. So hernias are not uncommon. I've picked up 2 actually in practice since I started. It's not a routine part of my exam, but if something sounds a little weird or different, then it's something that you will catch. Trochanteric bursitis being obviously more lateral-based pain, iliopsoas tendinitis, or kind of active activity, flexion activity-based pain. And then the spinal stenosis or back radiculopathy is really a big overlap with hip pain. So kind of figuring out the differentials between those 2 is important in your history and physical. And we're not going to go into too much depth about that. But the other thing to just be aware of in a joints clinic or any clinic is always looking joint above, joint below. So referral for knee pain. You know, if this patient comes into your clinic, they've seen 5 providers before, their x-ray looks normal. You know, they had joint injections, didn't really help, you know, then just get a hip x-ray. A lot of times they'll have pretty bad arthritis. Same goes for a painful total knee. People will go through the whole process and get a total knee. You'd be surprised that no one's actually looked at their hip, and their hip has been the problem all along. All right, physical exam. So you guys know all this stuff, but you know, Fabian, what's the difference between a Trendelenburg gait and a Trendelenburg test?
So for Trendelenburg gaits, usually when they're walking, their contralateral side will dip down from their ipsilateral affected abductors. Trendelenburg test, I believe, is when the gait. They'll try to. That's the test. This for the gaits, they'll tend to lean their center of gravity over the effective hit to decrease the moment arm of the body weight over the center of the hip.
Yeah, perfect. So Trendelenburg gait is, they're both the same thing. They're both positive. You have a weak abductor, right? But Trendelenburg gait, You're leaning towards the affected side to kind of bring that center of mass closer to the hip, decrease that moment arm like you're talking about, decrease the abductor pull, and then Trendelenburg test is just when you're standing, the sound side sags, right? So the good side drops down. Other parts of the exam, just kind of getting provocative tests. So, we went over all this last week, but, Stinchfield is the resisted straight leg raise. And then you also have your IT band tests and other things like that. Jesus, it's dinging all over the place. Sorry, guys. Okay, and then don't forget to test back and knee for the hip. And this is just the difference between a coxalgic gait and a Trendelenburg gait. You're both limping, but you're and leaning over to reduce that moment arm. But with a Trendelenburg gait, that hip is dropping on the sound side because your abductor is not holding it up. And we'll go over these force diagrams in the biomechanics section in a little bit. But again, it's just moving that center of mass closer to the hip center of rotation, decreasing that moment arm, and that's going to reduce your joint reactive force quite significantly. Now, if someone has hip and knee pain at the same time, they're both arthritic. Tiffany, which one do you think should get replaced first? They're both indicated for surgery, hip and knee. Which one would we usually replace first?
I thought the recovery for a hip replacement is slightly easier, so you would maybe consider doing that one first.
Yeah, that's one reason. The recovery from a hip replacement is easier. The other is that usually, hip arthritis can sometimes refer to the knee. So sometimes you'll eliminate their knee pain by just doing the hip replacement. The hip replacement is an easier recovery, so you're less likely to scare someone away. And then the other reason is that often if their hip is very stiff, it can be hard to do a total knee. So getting the knee all the way flexed up or getting the leg flat is often difficult if they have contractures associated with a hip, whereas it's not quite the same issue if you're doing a hip replacement with a bad knee. And then there's also some changes in terms of if you mess with their offset and things like that, it can affect your overall stability and alignment of a knee. So doing the hip is generally the first that people will do if they have the same issue or equivalent pain on the same side. Okay, in terms of the radiographs that we're going to get in clinic, Sarah, what's the diagnosis of that X-ray right there before we go over what the basic radiographs are? Just you get 3 words.
Degenerative joint disease.
No, hold on. Let's see who else. I mean, it is degenerative joint disease. I mean, that's everything technically. But what's the diagnosis, Fabian?
FAI.
Oh my gosh, no. Are there any other? Let's see. How? We'll just jump up a little bit. How? What is it?
Sorry, your screen is actually blocking the view for my X-ray. I can't see the whole thing.
Well, you didn't need to see the whole
I'm trying
thing.
to move it.
What do you need me to move?
No, it's just my I'm on my phone and I just can't see.
Erica, someone, three letters.
ABN.
ABN, thank you.
ABN,
Okay.
yeah.
Yeah, so see the big divot.
Sorry.
All right, great. Okay, so standard imaging that you're going to get on an X-ray in an arthritis clinic or in a joint clinic, a low AP pelvis. Freshman, what's the difference between a low AP and a regular AP?
Low AP, you can see more of the distal portion of the femur, and you don't really see the iliac wings, whereas the regular AP pelvis, you're going to see like the iliac wings, and it's going to be a little more proximal.
Yeah, exactly. Low AP pelvis should be centered at the hip joint. Okay, so this one's actually a little low for a low AP pelvis, but a low AP pelvis should be centered at the hip joint, whereas an AP pelvis is more, you have to center, you're just trying to get the whole pelvis in the film. Usually people get a frog lateral, plus minus a standing AP. for standard imaging. And then post-op is when we start getting more of the cross-table laterals and things like that. And then PRN getting Judet views or pelvic, spine views, depending on what we're trying to get. So in terms of how an AP X-ray is done, toes are internally rotated 15 degrees to get rid of the anteversion of the femur. You're trying to get that neck perpendicular to the beam of the X-ray. So that's why you're rotating the toes in 15 degrees and then shooting straight A to P. And again, people with different version, that's why sometimes the films will show up differently. Even though the techs are doing 15 degrees, you'll still sometimes see people with crazy external rotation or internal rotation, and that's just because of either pain and contractures or different shapes of the femoral neck. So a good AP pelvis is not necessarily what we want in a joints clinic. So this X-ray on the left with a distance from the tailbone to the pubic symphysis and kind of, seeing the entire pelvis, seeing the top of the wing up to L4, all those kind of characteristics that they talk about of what a good AP pelvis is not necessarily what we want in a joints clinic. I'd much rather get a film like this on the right in a joints clinic. Number one, it's a low AP pelvis. Number two, I want to see what their functional position of the pelvis is. A lot of people don't have that perfect kind of balance of inlet-outlet view and that perfect distance from the coccyx to the pubic symphysis. And I want to know what their functional positions are. Usually these are shot lying down, which is going to be similar to what they're going to be in the operating room, but even more important is probably what they look like when they're standing or when they're sitting down. And you can't get an AP of a pelvis sitting, but you can get one of someone standing. And a lot of times when people are standing, the pelvis will roll back and you'll get more of this outlet view. There's a lot of data coming out that that's probably a more important view and position of the pelvis in terms of dislocation risk and a lot of other things than just the anatomic AP pelvis, which is an artificially positioned pelvic obliquity. Okay, so when someone has a crazy outlet view or a crazy inlet view, that's not necessarily a bad job on the tech. That's just where that person holds their pelvis in space due to their hip contractures or due to their spinal disease or just their normal lordosis. So don't necessarily look for this distance or the perfect inlet outlet. What I care more about is rotation. So if I was going to be critical of this X-ray, a little bit rolled to the left, right? This symphysis is a little to the left of the midline. Patients rolled a little bit left side down. In terms of the lines you can see on the AP pelvis, these are the same as just your trauma clinic. The 6 main landmarks around the acetabulum, anterior wall, posterior wall, sourceal, ilioischial line, Kohler's line, and the iliopectineal line, and then the teardrop as well. In terms of frog lateral, Erica, why do you think we get a frog lateral instead of a cross table lateral for pre-op joints clinic?
The frog lateral gives you a better lateral of the femur. So potentially you can see osteophytes at a different location on the femoral head. And then, the cross table lateral is a better view. Best to have them in its version. And so I guess, you're not necessarily evaluating that as much preoperatively. Right.
So when you're doing a hip replacement, the socket, 99% of primary hips are going to be a hemispherical socket, right? And usually any deficiencies in the anterior posterior column or posterior wall, you're going to be able to see on that AP when there's no metal in there, especially. So you don't really need that cross view of the acetabulum. The femur, on the other hand, you can have deformities in the AP plane of a femur that preoperatively can really change what you're going to have to be able to do, or what kind of implants you're going to need available to you. So it's very important to see that lateral view of the femur preoperatively. And then postoperatively, it's probably more important to see the lateral view of the socket to make sure, number one, that you're where you are, A to P, but also looking at your version. So that's why we kind of change the images that we get pre to post-op in the arthroplasty. All right, and so this would be more of a cross-table lateral. It's going to let you see behind that socket better. And so like this example of this hip, there's a huge lytic defect behind the socket, right? Version's okay, but there's a huge defect behind the socket. It still gives you sort of a lateral of the femur, it's not quite as good, and that's why it's often rotated funky, and that's why we don't do it as the sole lateral pre-op, is that a lot of times this femur gets a little bit distorted by the angle of the shot. Okay, does that make sense? Now, in terms of OA grading, Kellgren-Lawrence is probably the most common one that we'll use in most joints literature. 0 to 4 with the characteristics of osteoarthritis, osteophytes, narrowing, sclerosis, cysts. That said, usually in our clinic notes or for billing and things, you do have to list a lot of these things, but you're not going to give it a KL grade necessarily. It's just mild, moderate, or severe arthritis, mostly based on joint space narrowing. And then you can comment on cysts and osteophytes as well, but this would be kind of a grade 4 OA here. This is more of actually a rheumatoid looking hip. Tonus grade is something that's used more frequently in the sports clinics or in the peds clinics. Another grading system for arthritis, a little more shifted towards the milder OA for these grades, and that's why they use them in those clinics more frequently, whereas the KL is a little more shifted towards differentiating between bad arthritis grades. This is just one of the things that often they'll test you on is sort of the difference between coxa profunda or acetabular protrusio. And so with profunda, it's when the femoral head goes to the level of the ilioischial line. And then acetabular protrusio is just one step further when the head is going beyond that ilioischial line. So this guy actually has protrusion on one side, profunda on the other side. In terms of when we're talking about varus and valgus necks in the femur, this is a really important point. Number one, you need to make sure that the rotation of the image is correct, that you're getting that perfect en-face view of the neck. But then when you and you can usually tell that by kind of the anatomy of the lesser troch and how much you're seeing. But then if you look from the tip of the femoral head across perpendicular to the shaft, looking at where that tip of the greater troch goes into the femoral head relative to the center of rotation of the head can give you an idea of the varus or valgus nature of the femur. Technically, varus valgus is based on the angle of the neck, but this is kind of a surrogate. You can imagine if someone had a very long neck, but 110 degrees, they're technically not, say that came out all the way to here, that's technically a normal height of the center of rotation, but it would still be coxa vara by the angulation. These are important in terms of when you're going to template, and we'll talk about that in a little bit, but Charlie, if we had a valgus neck, how's that going to change our femoral component position?
Well, our neck cut is probably going to be a little bit higher, and it's going to change the type of stem you want to use for your offset probably as well.
Yeah, you're going to want to use what? High offset or normal offset?
Normal offset.
Yeah, usually you're gonna be fighting to avoid putting too much offset. So you're absolutely right. Higher neck cut, and the opposite for a varus neck, you're gonna be cutting lower so that you're able to add more head length without getting too much leg length. All right, and then the neck of the femur also important to remember that there's two real planes here that we're worried about for the femur. There's the anteversion of the femur and then also the neck shaft angle. So anteversion decreases as we develop. Normal is like 10 to 15 degree range, but everybody's a little bit different. And when we get into the surgical aspects of things, we'll talk about that a little bit more. Okay, acetabular anteversion. The reason I put a picture of Einstein here is that it's all relative. So this is like one thing in the orthopedic literature that as a resident was incredibly confusing to me because it's not consistent. Okay, when people talk about version, the way that they're defining anteversion is different in every single paper and every single way that they're measuring it. And anteversion is always a relative measure. So you can do a CT scan and measure similar to what this one is doing, an axial cut, to get the version. But again, that's going to be dependent on your pelvic tilt as well. So unless you're you're standardizing your pelvic plane, this version angle is always going to be different. I can tilt my pelvis forward, tilt it back, get a CT scan of each position, and it's going to be different even for me when this should be an anatomic number. So just be really careful about everything you read about acetabular anaversion. It's all relative. But in general, it's some degree of kind of that forward-facing, open shape of the cup. All right. So hip biomechanics, we just missed National Biomechanics Day to talk about this, but we're close. Hip biomechanics, so the normal range of motion varies greatly in individuals. Most people, if someone's in my clinic and they're in normal range of motion, I'm just going to put flexion 0 to 120-ish, extension to neutral. Abduction, most people can get in the 30 to 45 degree range. It's hard to isolate the hip for hip abduction. It's very much your spine will kind of get into there a little bit. So this normal is kind of the 0 to 40. Adduction is again kind of 0 to 20. External rotation is very different for everybody, but in the 70s-ish range, 50 to 70s. And then internal rotation is the one that varies the most. Will, what are the 3 things that you lose if you get arthritis? Which of those 3 are the 3 that are most commonly affected by a classic osteoarthritis pattern?
As you lose internal rotation, extension, and adduction.
Yeah, perfect. Yeah, so those are the 3 that you lose first. Internal rotation, extension, adduction. It just has to do with the classic, where the fights start to grow, and then also where the capsular contractures happen most frequently. The hip, you can think, so all those biomechanic diagrams use the hip as kind of a fulcrum with 2 main forces on both sides, body weight and adductor tension. So if you look at it this way, the joint reactive force is then going to be the total sum of the body weight and the adductor tension. And these have to be balanced with each other in the most simplest of diagrams. And so the distance from that center of rotation is very important and will dictate kind of the forces that are required. So, moving that fulcrum twice as far away or moving it half the distance towards one is going to double the overall joint reactive force just as a result of needing to balance. So if we look at that in more of a body weight abduction force sense, if we move that body weight closer to the fulcrum, it's going to decrease your abduction force needed. So that comes into play when we're talking about these single limb stance diagrams with a lurch. So if you lean towards the effective side, you're moving that body weight number closer to the hip joint. That decreases the amount of pull that the abductor has to do to accomplish the same balancing, and then decreases your overall joint reactive force. So really important to know these diagrams. They're almost on every in-service training exam and on the boards consistently is some variation of this diagram. So being able to just quickly do the math on these is good. Now, where that comes into play in joints is kind of medializing the hip center of rotation. You can imagine that you can either move the body weight closer to the joint center, or you can move the joint center closer to that body weight number, and both are going to accomplish the same goal. So in joints, historically we would move that socket as close medial as possible, obviously not as close as this guy, but you would try to get medial, and then that's going to decrease your joint reactive force and also decrease the stress on the implant as a result. The other advantage that you can get is via offset, and so here this is just another way of doing that same calculation. Okay, another way you can decrease the force is through offset. So in a Varus hip, or if you have a high offset, what that's doing is it's increasing the lever arm for your abductors, decreases the pull that they need to do to balance that same body weight, and subsequently improving the force. Opposite for a valgus hip, less of a lever arm for the abductor, and so higher pull needed from that abductor to balance the body weight. Also in dysplasia, the hip center is getting moved lateral, and so that's also increasing that effective force of the body weight. So double negative for a valgus hip or a dysplastic hip.
Dr. Barry, I have a question for you.
Yeah.
So can you discuss the increasing offset of an implant and how that affects things? Because when we're looking for increased stability, like in the OR, we talk about potentially increasing offset, or maybe a reason why Dr. Hansen often uses a high offset stem. They're not necessarily a coxivara type person, and that tensions the abductors, I think, is what helps us with the stability. But that abductor tension is not, I always thought that was therefore increasing joint reactive forces because that increased tension, but are we saying that it's decreasing joint reactive forces with increased offset?
Yeah, so it's that's kind of, if you draw the force body diagram in the ML direction, that would be more of the way that increasing offset is going to help with your stability. So this is purely in kind of the vertical orientation that we're balancing the force diagram, right? So we're doing body weight to abductor pull straight up.
Okay.
It's obviously a simplification. If you increase that offset, the joint reactive force in the vertical direction is going to decrease because your pull is going to be less. However, the reason that we do it for stability is that the push inward. So by tensioning that abductor, it's kind of pulling the whole, you're tightening the muscle base tension. It's going to pull the hips in towards the center. So it will increase your force in that regard, in the sense that it's holding it more towards the midline. And that's why you're getting that increased stability from higher offset. The other thing that a higher offset is going to do is usually that when we're doing that, it's pulling the femur farther away from the pelvis. All right. So as you get farther away from the pelvis, it's longer until the femur is going to start hitting the pelvis and impinging, which is usually how you lever out. So there's two ways that offset usually increases your stability. It's, number one, it's that increased ML tension. And then the other one is just pulling the femur farther away, so it's a longer distance to impingement.
Okay, so medializing the cup will decrease the lever arm for the body's pull. It decreases the body weight and then increases the lever arm for the abductors. So therefore, the abductors have to pull less force in order to match the body weight, and that's how you decrease joint reactive forces, by medializing the cup. But if you just lateralize the cup, then all of that's sort of reverse. The abductors have to pull more, the body weight, force dragging distally is more. All of that, as you were talking about in the vertical plane, is sort of what we're talking about.
Right.
I think there's a lot of OID questions that compare one arthroplasty like template to another, and then how that affects the force diagram. So those are always kind of
the force diagram. Always think about, whenever they're doing the force diagram, it's always vertical. So it's always this. So you always have the body weight usually and the distance from the center of rotation. So you multiply those two together. That has to equal the distance from the center of rotation to the abductor times the adductor strength. So usually this is the only unknown, is kind of that adductor pull. And the farther away that abductor is, the better. So like this is 1,000 for the abductor pull, 1,000 newtons, and times 5,000, 10 times 500, 5,000, those balance in the vertical direction. If you were to move this out farther to 10, say you increase the offset just straight out to 10, now you're 10 away in both directions, then this is going to decrease to 500 newtons. So by doubling the offset, you would have decreased this an additional 500 newtons of total joint reactive force. All right, same things if you switch this. If you flip this around and said that this center of rotation was 5 away from the body weight, now this is going to be 2,500. You only need, this was the same. So if you just shifted this over, so you just put this cup more medial and it's 510 here, you're going to switch these. So it'd be 500 and then, what is this, 250. So it even less.
Okay.
That makes sense. But yeah, don't think of it in the stability sense for these force diagrams, because that force diagram would be kind of an ML push.
Gotcha.
And we're not looking at that in this. The overall amount of that force is minuscule compared to the body weight.
Gotcha. All right, thanks.
All right. There's Valgus Hip. Jet skis, low weight. Okay, Trendelenburg gait. Again, we talked about this already, but the way that that's working is that you're decreasing that moment arm of that body weight force. So as you lean it over the center, you're getting closer and closer to the joint reactive force being almost purely just body weight. So if you got this body weight to go straight down through the center of the femoral head, Monica, what's going to be the joint reactive force if the body weight is right on top of the femoral head?
The joint reactive force would just be what body weight is.
Yeah, exactly. So it would just be body weight. It'd just be the weight above. So you have no abductor pull if you're straight above. And that's why it's almost a necessity to do this to keep from falling over if you have no abductor, because you would just kind of fall over to the side. Now, where this gets a little bit confusing is that this can sometimes confuse people, and this is just doing that same thing. I'll get there in a second. When it comes to canes, that can get a little bit confusing. Now, in terms of things that gain a mechanical advantage for the abductors, we kind of talked about this already. So higher offset is technically better for the abductors from a joint reactive perspective. It's not necessarily better to them from a bursitis irritation perspective. But the farther lateral that troche is, the less they have to pull. It's a better moment arm from that pull to the center of rotation, so a less force needed to counteract the body weight. The same thing is done by moving that acetabulum medial. And the same thing is also done by increasing the neck length, because increasing the neck length is giving you leg length and offset. So it's that offset that's giving it a better mechanical pull. Now, in terms of like the way people walk, now this is a little bit confusing because we just went over that if you lean over the hip, it's going to decrease your reactive force. So, Sarah, is this how people should walk with a cane?
No, you should be using it in the contralateral hand to the injured hip.
And so why is that?
I'm not sure.
Who else is on? Kogan, why do you want to use the cane in the other side? Like I just said that leaning over the hip is going to help with the joint reactive force. So why isn't this the proper way to use a cane?
So if you have a cane, then you think of that force diagram. You have a really long lever arm going out to the contralateral side, and you actually will be able to counteract the force needed in a downward force vector by putting body weight through the cane.
Yeah, it's more efficient to do it from the other direction. So that's like not the way to do it. It's more of to put it on the far side. So if in this patient the right hip is the one that's affected, you get a more effective decrease of the joint reactive force by using the cane in the opposite hand, having a huge lever arm to the center of rotation of the hip. And so you can get a much more effective decrease of that joint reactive force just because of that huge moment arm. So if you put it in the same hand, you're still getting that lean, but the amount of push that you need to put on the cane to decrease that body weight is much higher. So you have to push a lot harder because you're closer to that center of rotation to get the same decrease of joint reactive force, the same offset of body weight. So, you know, the number that they sometimes ask is 50% of body weight to the cane normally decreases that joint reactive force by 50%. So it's a really effective tool. Now, most people will still limp when they're using the cane, and that's that same thing, right? You're still moving that center of gravity closer to the hip by the lean, but then you're just offsetting with this additional force vector coming from the cane. So absolutely right, needs to be in the opposite hand, and it's because of this huge moment arm, okay? Again, this is if you were to draw that force diagram out, why the cane is so effective, okay? So the lean pulls your body weight a little closer to the hip center, but then that force from the cane is gonna really offset the pull that needs to be done by the abductor to balance. Okay. All right, freshmen, so cane in the contralateral hand is reducing the joint reactive force by about 50%. Through which of the following mechanisms?
Increasing hip abductor muscle pull, increasing hip thrust, and not number 2, moving center rotation of the femur joint, not 3, not 4. So based on what we just talked about, 2, because you're using that cane to kind of, or sorry, 1, using that cane to offsets the force needed by the abductors.
Yeah, exactly. Instead of just having this abductor counteract this body weight number, you now have this plus this. So it's decreasing the abductor force. So when you add all these numbers together, or add these two numbers together now, it's a much smaller total sum going across the joint. All right. Sorry, I can't see everybody who's on. Marcus, you want to do this one? Oops. Sorry.
All right. Figure A represents the free body diagram of the hip of a patient sitting on the right leg. Oh, let's minimize this. The forces are labeled on the diagram. Hip joint force of 1,800 newtons. What is the resultant value for J when that's blocked? I think it's acetabular. That component is medialized, giving the new distances shown in figure B.
So basically you have 600-pound body weight force, 1,800 joint reactive force if your center of rotation is 100 away from the body weight and 50 away from the adductor pull. What happens if you move this or move this center of mass 50? So now you're equal, right? So it's the same 650 away. What's your abductor pull here and what's your resultant joint reactive force?
All right, so if we're moving that medially, our abductor pull is going to go up, and we moved it by 50.
Well, so yeah, so you're moving the body weight closer. Ignore all these numbers. This is a stupid diagram because they didn't move anything. It all looks the same, but you got these numbers at the bottom.
Oh, I see. We just made B smaller.
Right.
So if our body weight moved medially, then there's going to be less force coming down on the joint. So our abductor pull actually had to be less, and the distance was cut in half from the center there. So I'm guessing our adductor tension would be 600 newtons.
Good. So the actual question is saying what is the joint reactive force?
Oh, the joint reactive force then will be should be cut in half as well, right? So before it was 1,800, so we'll go down to 900.
No, not quite. So joint reactive force is the sum of the forces across.
Oh yeah, so then it would be 1,200. It'd go down by just the 600.
Yeah, exactly. So 1,200. So it went down. So it's 600 adductor tension, 600 body weight, add them together, 1,200. So it went down by a third. Okay.
Yeah.
Good. Okay, so that was like 40 minutes. Do you guys want to take a quick break before we move into the hip principle talk? Anybody vote? Just keep going.
Let's just keep going.
Sure. Okay. So hip principles. We want to get this one on the right. We don't want to get this one on the left. So the goals of total hip surgery: decrease pain, maximize survivorship, ensure prosthetic stability, and then recreate anatomy. Those are the goals, and then avoiding Hansen head shakes in the OR. So templating, we went through this in conference a couple of days ago. Let's give Laura a chance. Which one? So ignore the question. I'm going to ask you a question and then tell me which one is the right one of these. So which one is going to keep leg length the same and decrease offset?
Should be the middle one.
Good. Howell, which one's going to increase leg length? Decrease leg length, keep offset the same?
It should be the second one.
Good. And Fabian, which one's going to increase length and offset?
The one on the left, very left.
No. Abby? Decrease length or increase, sorry, maybe I asked it wrong. I meant increase length, increase offset.
Is that to me or to us?
You can try again.
That'll be the first one, right?
No,
Uh,
Bobby?
Second from the right.
Yeah, the fourth one. Okay, so when we're doing these, you're moving the dots together, right? So this is going to be the center of rotation of the hip on the femur. This is the acetabulum. So that first one is actually going to decrease length and offset, right? You just move them together. When you reduce the hip, you move the dots together. This one's going to decrease length, offset the same, decrease offset, length the same. This is the femoral head one. That might have been what confused you, is that the dot, they've just put on a longer head. So this is the femoral head dot. Increase length, increase offset. This is going to increase offset, length the same. Okay. So why do we template? Try to avoid problems in trop. Try to anticipate weird anatomy, and then predicting our sizes. It's generally pretty accurate. You're usually, with a digital template, you're within 2 sizes on the femur and 2 sizes on the acetabulum pretty much 95% of the time. The goals of templating: try to get the center in the right position, restoring femoral offset, equalizing your leg length, and then overcoming a lot of these things. So stepwise approach to doing this, and I'm going to fly through this because we just did this a little while ago, but these are the steps that you should do every single time. This is what I do every single time too. First is make sure you have good x-ray and make sure your magnification is right. Then get your leg length difference. Put your acetabular component where you think it should be, put the femoral component where you think it should be, and then tinker until your leg length and offset are what you want them to do. So this case example, just looking at this is sort of a low AP pelvis, is a little bit of an AP pelvis, but osteoarthritis on the left side. If we're looking at the quality of the film, looks pretty good. In terms of the rotation of the image. Also, our femurs looks like they're probably internally rotated appropriately how we want, with that smaller, lesser troch. If it's not obvious to everybody, you just need to make sure, externally rotated films, you're going to see more of that lesser troch. Internally rotated films, you see less of the lesser troch. Everybody's a little bit different, but if you look at here, this would be, if you see a difference on one side versus the other, that gives you a tip off that one of them may be off. Now, people lose internal rotation with arthritis, so sometimes it's impossible for them to get to that proper position, which is why if you're templating, it's always a little safer to template a little bit of increased offset as opposed to decreasing offset. Increased offset is probably going to be more accurate to the intraoperative findings because you're going to get more of that perpendicular view, the full neck length. So getting the leg length right. You can either go off the bottom of the ischiums or you can go off of the teardrops. I would recommend going off of the teardrops. It's much more consistent. So if you draw a line across teardrop to teardrop and then drop it down to some consistent point on the femur, that's going to give you what your leg length difference is going to be. Make sure it makes sense, right? If they're arthritic on the right, they don't really have any deformity, but then you're reading that the right side's longer, you probably have one of your lines off. So just adjust accordingly. And they're close, but they're sometimes different. Whoever did this talk was going off of the one that I probably wouldn't have picked. But once you have the leg length, next step is going to be doing the acetabulum. So positioning that component where you want it to be. Everybody has differences in terms of what they want for their socket. Some people want to go down to that teardrop to medialize the cup. Medializing the cup does what, Fabian, to our joint reactive force?
It will decrease your joint reactive force.
Right. So that's historically why everyone would try to put it deep to that teardrop, try to decrease that joint reactive force on the socket. Now I think most people will put it where it's appropriate to recreate the anatomy. The other thing to be aware of is that you don't, this one you'll see them move it eventually, but this is a little deep. You don't want to be so deep into the subchondral bone, because that cancellous bone is going to be really soft. You kind of, when you're normally reaming, you get to where it's just kind of spot bleeding. You don't want that purely foamy cancellous bone looking appearance, because that's going to not be as dense and you're probably going to have issues with subsidence of your components. So there's probably a little bit of an aggressive ream right now, what it's showing. Next, you're going to move to the femur and start putting the femur in, and then start sizing. You have to make sure you're fitting inside the canal up top and below, and that there's not a mismatch. Some people do have mismatch, and if that's the case, you need to be prepared with different stem options. So how if we had this, put that head ball on, what's going to happen to leg length and oh shit, it says it on there. Never mind. So
It's gonna lengthen a little. Yeah.
yeah. Good job. So how would we adjust this one? What would you want to do to try and make this better? How? Tell me what your next steps are in this template.
All right, so the leg length, so the right side is one shorter. So we do want to get it a little bit, increase the leg length a little bit. I think we want to increase the offset as well. So I'd want to see if we can get a bigger template to see if we can do that.
Okay, so what are some ways that you can increase the offset? So we're short on in this case, right?
Right. Yeah, we can do like a high offset template, and
so
it depends on where you can move the stem on the template.
Okay. So tell me what you're going to do to this one. This is already the high offset stem.
Already high offset stem, right? I'll see if I can increase the size. You can also increase the femoral head attachment. It's at a 0 right now, so you can get that up to a 4 or 8.
Okay, so we go to the 8. Say we go to the 8, which is this dot of where my point is. What's that going to do to our overall?
But then our leg length would increase more. So then you'd have more of a leg length discrepancy that you're worried about.
Okay, so what are some things that we can do to fix that?
I would try to play with the size.
Okay, what do you tell me what you're gonna do? Go up, go down?
I would tinker with it. I would see what would happen if I went down with the size and then up with the femoral head attachment.
Yeah, good. Fabian, does that make sense? So what he's saying is we need to get this, say we went to this +8 ball, that'd get our offset good, but then we're too long. So we need to get that stem farther down in the canal to get the leg length closer to equal. We don't want to lengthen them by a centimeter just to get our offset back. So what you can do is you can, usually decreasing the size of the stem lets you go deeper into the bone. Increasing the size is going to sit you up higher. So if you decrease the size of this stem, go down farther, lower neck cut, and then add more length and offset with the head, that's going to get you closer to these dots being aligned. So you can imagine just moving, if you move this stem straight down about a centimeter, these two lines would match up. This X and this X would match up. And that's going to be closer to what you want. Trevor, what's another option for this?
You could do a lateralized liner as well.
Yeah, lateralized liner. Which is a lateralized liner going to put your center of the acetabulum here or down here?
The first option you listed, it would move the acetabular dot directly lateral.
So it actually moves it straight out. So it goes in line with the axis of the acetabular component. So a lateralized liner will just give you, it's going to give you length and offset similar to a head. So that's not going to purely fix our problem. Geiger, what's another option?
The question was just the increase offset.
Yeah, how can we increase offset without messing with the stem?
And we talked about the head and the cup. I'm not sure.
Well, so the cup, we didn't really talk about the cup, right? You said a lateral liner, but that's going to give you length and offset. What's a way to?
If you do maybe a slightly bigger cup and then not medialize so much, you could not be decreasing your offset so much.
Yeah, exactly. Just don't medialize as much when you ream, right? Leave this thing closer to the cortical bone. You can straight lateral. That is totally reasonable. So in cases where there's a lot of offset, sometimes you have to do all these things to keep the anatomy there. So keep this socket more lateral. That's going to move this dot straight lateral. Put a smaller stem deeper, lower neck cut, and then a longer head, high offset stem. All those things are going to help you keep out. Sometimes you do need to use that lateral liner that Trevor's talking about, which is just basically a thicker liner that pushes you out. Sometimes you do need to use that because, you know, your neck cut will be so low that you're in these extremes of the femoral head. And so that's going to help you kind of balance the two. You don't want to be on the extremes of any system when you're templating, because then you have no room to play.
Makes sense.
Quick question.
Yeah.
Since you had said both, like increasing the femoral head and increasing like lateral liner, both basically do the same thing: increased offset, increased length.
Yeah.
As you said, at the extremes, you don't want to be at the extremes for either one. But when you're in the middle ground, how do you pick which one to like preferentially like?
Yeah, that's a good question. That's a great question. So go back to your diagrams, right? So if you had a choice between doing a femoral head lengthening or a lateralized liner, which one is going to be better for you from a joint reactive force perspective?
It would be the head, right?
Yeah, the head, because the head doesn't change your hip center of rotation. The lateralized liner changes your hip center of rotation. So a lateralized liner moves that center of rotation lateral and distal. So both of those are not going to be beneficial for you. So if you have a choice, most people will do a head change, right? Where that comes into play and where you start kind of maybe going the other direction and using the lateralized liners when you get to the extreme heads that have skirts on them. For other reasons, you want to avoid skirts. So the extreme head options with skirts, sometimes it's better to do that lateralized line. The other reason sometimes people do lateralized liners is that because it's a thicker poly, you get more polyethylene kind of in the bottom of the cup. So sometimes that's advantageous from a longevity perspective.
Cool.
Okay. These are some of the ways that different companies do different offset options for a stem. So just important to know that the difference between different implants and why it's important to know your system. So you can increase the neck length. That's one way to increase offset, but you're also going to increase leg length, right? So this is just in line with this. You're going to get both increasing. Everybody's a little bit different. Every company's different depending on that neck shaft angle, what the addition of length is. The other way some companies do it, like the striker implant that Hansen uses, is a decreased neck shaft angle. So when you use the high offset stem, it's changing the angle of the shaft. So as you add head length along this line, it's giving you more offset and less length per increase in millimeter of neck length. And then some companies just shift the whole thing medial. So this is what DePuy does. DePuy will just shift this whole thing medial, and it actually keeps the leg length exactly the same when you go from a standard to a high offset. So what they did in this one to get this one a little bit closer is they shifted the cup lateral, sunk the stem a little bit deeper, and then they should have clicked the +4 number here. They didn't. This isn't quite perfect, but should be sunk a little more and with a +4 head. That's how you get these closer. Okay. This is just quickly, we'll kind of talk about this. So this is kind of just showing that if, let's see, Charlie, what's going on with this femur on this side? What might be tough about template?
It's quite a valgus neck, so probably want to, it'll be tough to get the proper offset and leg length, especially if you compare it to the contralateral side where it's quite a varus neck. So that could be.
Do you think that's how they developed? Just one side developed valgus and one side developed varus?
No, I mean, could be compensatory. It's also, I don't think we have we don't have an equally rotated femur on each side. I think I see we're a little bit more externally rotated on the.
Oops, sorry. Sorry. Yeah, no, I think that's the bigger point, is that this is a very externally rotated x-ray, right? So when you're seeing this whole kind of troche like that, this is very externally rotated. It can give you a false sense of valgus. So just be really careful when you see such a prominent lesser troche. It's hard to see the difference on here because of the overlap, but this is actually a lot less rotated than this side. It's a shitty film all around, but just be careful when you see a very externally rotated femur. You're going to get way thrown off in terms of what the valgus amount is. So just be really careful when you're templating these. These are hard to template, and we understand that, but try to get the size of the femur a little bit better on the side that's a little better. Any questions about templating? Obviously, there's a lot of nuance to that, and not the main focus of this talk. Okay, surgical approach is also not the main point of this lecture, but just briefly, 3 main approaches or 3 main kind of used in the world. So anterior approach or direct anterior. Advantages being your supine, so you get the advantages of radiographs, and then also it's an intermuscular internervous approach, so theoretical advantages in terms of the amount of damage that you're doing to myotendinous structures. Disadvantages of anterior approach being technically more femoral exposure is harder, and probably more wound healing issues. Anterior lateral or direct lateral approaches have the advantage of the best stability, but the worst functional scores consistently. And then posterior lateral or superior approach being very extensile, versatile, and tried and true. So there's a ton of stuff comparing anterior to posterior approaches, kind of like comparing Tom Brady to Joe Montana. They're both probably pretty good. And then the direct lateral is more like an Alex Smith. It's not going to win you very much, but you're also he's not going to be the reason that you lose. So anterior lateral is probably less than 10% of surgeries in the U.S. In terms of intraoperative tips and tricks, so this is just some general themes in arthroplasty that I thought I'd put in. So Dr. Jurgensen used to say this, that we do it the same way every time. He was saying it from an efficiency standpoint, but it does apply a lot in joints. And the reason that we're doing that and standardizing is you're trying to eliminate outliers and trying to eliminate bad complications where it's appropriate. But there's obviously some things that have to be different patient to patient. More than any other specialty, you need to know your system in arthroplasty. So we ask a lot of just kind of random shit about implants and, like I just said, the offset changes differently from company to company. All those things are important, and so it is a little bit trivial, but it's also important in the operating room to know the differences amongst different systems. This is something that's just more of a life quote, but from an arthroplasty surgeon that I train with. Good and slow can become good and fast. Sloppy and fast is never going to become good and fast, so important for you guys as you start getting into practice. And then no wrinkles in orthopedics. I think the way I take that in arthroplasty is that little errors can begin to compound themselves. So say you're doing your socket, you put your socket too deep, it's too medial, just like that case we were templating, you then may not be able to catch up on your offset on the femur no matter what you do. So you just need to be cognizant of the effects of each step you do, and then don't palm the bovie because it hurts. All right, so intraoperative tips and tricks in terms of planning, you need to have the correct instruments. So sometimes that is the kitchen sink. You don't always know what you're going to get when you go in there. So template and anticipate roadblocks. In terms of exposure, make sure you're picking one that's going to set you up for success. So you may not want to be doing a posterior approach for a total hip in someone who's wheelchair bound with big long spinal fusion, with a sacral decubitus ulcer or something like that, right? So staying away from areas of trouble. And then in exposure, don't be afraid to extend your incision. And if you can expose a big complex case, you can always get there for a primary. It's just a lot of times we're hesitant to do more releases or things, but you need to be able to see what you can do. Otherwise you end up with stuff like this. So real important, just not just arthroplasty, but everything. In terms of tips and tricks for the acetabulum, in terms of total hip principles, so you want to leave the osteophytes there until the cup is fixed in place. Really important to keep capsular slots. For retractor placement, you don't want to be putting retractors into vessels. In terms of judging acetabular component position, it's important to do this based on bony anatomy or soft tissue landmarks in the wound and not the room or the floor. So a lot of times people will say, kind of look at the handle relative to the floor. I would say be really careful about that. All those guides that say, if you hold this in line with the axis of the body and it's 45 degrees off the floor, then that's going to be your perfect cup position. You're going to be off a lot because the pelvis tilts. It's based on however you're positioned on the table, however the spine has moved that pelvis. So imaging or bony landmarks are going to be more effective. The quick and easiest way to get your version correct the majority of the time is to do this trick that Tom Faring does. So if you look at this image on the left, who's on here? Laura, is this image on the left going to be more or less anteversion than this image on the right?
More.
Was that?
More.
Yeah, more anteversion, right? So it's more tucked. This is the ischium, pubis, ilium, so more anteverted, right? So the way that you can, a good, quick, and easy landmark positioning trick is that for proper version, which would be something like this in the middle, you should have the anterior lip of the cup just tucked under the pubis and the posterior of the cup just proud of the ischium. That is almost consistently going to give you in that 20-degree aversion range. If you have the pubis covered or ischium showing, almost inevitably you're going to be neutral or retroverted. And if you have too much pubis showing and you're too exposed on the ischium, or too proud of the ischium, you're going to be too anteverted. So revision cases, primary cases, if you can find these bony landmarks, that's going to be a quick and dirty, easy way to get pretty good version on most patients. Okay. The other thing that you can look at that is similar to this is the TAL, which goes between these two landmarks. So trying to be a little bit more anteverted than the TAL. Okay. Sometimes that's not there though in revisions any longer. So this is unless you have really bad bone loss where you got to rely on imaging, this is going to be a good surrogate for getting positioning.
Hey, Dr. Berry, when you're using that as a tool or as a technique, a lot of times I'll see people put the cup in before they remove osteophytes and things. What are you doing if there are osteophytes in the way that are preventing you from doing this? And
yeah, that's a great question. That's a great question. So one thing you can do is you can put your finger on the ischium. So you can always get your finger around over the top of the osteophyte and feel where this ischium is, and then get a sense for the depth of that osteophyte in that area. Also, I will usually take off sometimes these osteophytes if it's really big down at the bottom, just so I can feel the ischium, or the inferior osteophyte down here, I'll take off before I ream. That was Hansen. This is Hansen's original slide, the osteophyte part. So I'll usually take off the osteophyte there if it's in the inferior part of the cup, but you can always stick your finger over the top of the osteophyte and feel this base of the ischium here to get a sense for how far beyond that phyte when you're looking from the inside is the actual ischium. And the same for the pubis. There's rarely a big phyte in front of the pubis, but if there is, you can, again, feel over the back of it and feel where that pubis is. And kind of get in your mind a 3D model of where that cup needs to be relative to the height of the osteophyte even.
Dr. Berry, just so I understand, what's the principle of leaving the osteophytes in until the cup is fixed? Is it about distorting bony anatomy?
That's a Hansen thing. The principle is a couple things though. Number one, leaving the phyte in will often, so take for example, you're doing an anterior approach. What happens if you put the cup in like this? So say that pelvic positioning wants your cup to be here. This is what X-ray says is your correct version. You end up with the cup exposed on the front. What's a downside of that? Do you know?
I mean, I guess you could impinge.
You could impinge. The other thing that's right up there is the iliopsoas. So if you have exposed cup in the front, especially, it can become very irritating for the iliopsoas. So we almost always try to have that lip of the socket deep to some sort of bony structure to protect the iliopsoas. So one advantage of those phytes is if you leave them there until you've positioned your cup, sometimes you can leave a little bit of phyte to help cover the front lip of the cup and prevent the iliopsoas from getting irritated. So that's one thing. The other thing is a lot of times until you've put the cup in, it's hard to tell phyte from small or weak posterior wall. So you don't want to take posterior wall away, which can be a risk if you're taking phytes out before you've put the socket in. you don't want the socket to be resting on the fight. So I think that that's kind of something that this is kind of leaning towards, like you may need the fight to give you fixation. That's not going to be a successful outcome, but it's more, in my mind, the only fights I'll kind of leave are those anterior fights that may give you a little extra coverage of the iliopsoas. Okay. Does that make sense?
Yes, thanks.
Dr. Barry, when you're finding a slot for your retractors, do you like to do what I think Bill does with a knife and create a little slit literally in the capsule to facilitate placement, or not really necessary? There's just paste, or what do you think?
No, yeah, I don't usually make like a bovie slot. I think the more important, you know, I think some people do. That's why that's on here. But the bigger thing is just making sure you're in the right plane. So your anterior retractor is the most dangerous one, right? And so making sure you're deep to capsule but outside the labrum is the safest way to do that. So that's that kind of he uses like the two fingers with the point between your fingers, right, to get over, so you feel labrum and then you're going right over the top of the labrum. That's his trick for doing it. I'll do something similar, but you can also just get used to feeling that tip of the retractor. You kind of feel the pop of the pop as it goes over the labrum, and then you put it in. That anterior release that Vail does, for people that aren't familiar, he's doing a posterior approach. You've kind of done your capsular split here. He'll put his knife under the front rim here and release that. He's not doing that necessarily for exposure for the retractor. He's doing that more to let the femur float anterior more easily. So this structure here is going to be your iliofemoral ligament is coming off of this region. So if you kind of release underneath that, it helps the femur fly forward more so than it's helping you get a retractor over the front.
Got it.
Okay. Another principle here is you want to keep your head size big, and there's two main reasons for that. Tiffany, you want to explain these two reasons for head size? So why is a 36 head more advantageous to a 28 head?
Well, like the figure is demonstrating, you get an increased range of motion before you impinge on the edge of the cup and start to lever out.
Is it the cup usually that you impinge on, or what usually impinges? What are the two things that hit each other?
I think it's the neck that hits the edge of the cup or the acetabulum.
Is it hitting metal or plastic usually?
Poly.
Yeah. So it's usually neck hitting liner.
Mm-hmm.
That's the impingement. So how does this? Mm-hmm. How does it? Why do we want to avoid skirts? What's happening in a skirted head?
So a skirted head, it decreases your head-neck ratio, so you essentially have a smaller arc of motion before the neck or the skirt now impinges on the liner.
Yeah, exactly. So it's the same thing as putting a smaller head. So imagine this head in A with a thicker neck. So if it was like a straight, you know, in the extreme, the head's the same size as the neck, it's going to impinge on that poly even earlier. So you want a thin neck and a big head. Those are the best that you're going to get, the closest to like 180-degree range of motion. What's the other thing a big head gives you? It's shown here on the right.
On the right, so it shows the I think it's a jump distance. So it's effectively the distance that the head has to travel before it jumps out of the cup.
Exactly. So even, you know, a hip doesn't dislocate as soon as it gets to a point of impingement. It has to continue impinge until that center of force or the center of the head gets beyond the lip of the cup. So up until here, it's still technically reduced, or it'll re-reduce itself. It's once this center of the head gets beyond the lip of the cup, and that's when it's going to dislocate. So that's the advantage of the big head. Twofold. It's going to increase that jump distance, but it's also going to increase the range to impingement of the neck. Now, I kind of mentioned earlier in the talk, it's not usually this neck on poly impingement when a hip dislocates. It's usually bony impingement, so the troch hitting the pelvis or troch hitting against a bunch of soft tissue or things like that. So this is all theoretically important, but not quite. Trevor, if I used a lip liner how does that affect this whole diagram?
We usually put the lip, which is kind of has an elevation on the side that you tend to lever out. So it kind of gives you an extra coverage to prevent jumping out in that direction. Effectively, it kind of increases the distance you have to go to dislocate the hip.
Yeah, good. What's the disadvantage of that maybe?
You could dislocate the other way if you impinge upon that.
Yeah. Avi, does that make sense?
Yeah.
So imagine this liner down here on B. If you filled this triangle in with more liner, what's going to happen is that if you impinged in the front, it has to go farther to get past that liner. So the liner is going to come out farther. It's got to go farther to get over it. The disadvantage is you're going to impinge the other direction a lot sooner. So your overall arc to impingement is less, but your jump distance is going to be higher in the direction that you're worried about. So that's how a lip liner usually works. All right, so when you're doing a femur on a total hip, regardless of approach, you want to avoid undersizing or malpositioning your stem. Version is very important on the stem. We always talk about cup version when we're assessing x-rays and things because it's easy to check, but stem version is just as important. The combined version is more important than the version of any individual component. So, if you look at that diagram in the bottom, if you have too much femoral version, your troch is going to hit your pelvis a lot sooner. You're going to risk coming out the front. If you have too little version, or if you're retroverted, the opposite is true. The front of the femur can hit the pelvis sooner, lever you out the back. Unfortunately, from an anterior approach, it's easier to over-antevert, which is dangerous for stability. And from a posterior approach, it's usually easier to retrovert, which is dangerous for stability. So you always got to be cognizant of that when you're doing the case. The other thing that I would say that you guys should always get in the habit of doing is after you've made that femoral neck cut, look at your version, okay? Look at the version of the femur. A lot of people are natively neutral. Some people are even natively retroverted, and you need to know that before you do your socket. You just blindly go on and do your socket and you do your 20 degrees of anteversion like you do every time. Then you go back to the femur and you're like, oh crap, this was a retroverted femur. You're going to be in trouble. You may need to add more version in your socket if you have something like that you don't have an implant you can adjust for. And then recreating anatomy, we talked about this already. There's a lot of ways to do that, but avoiding stuff like that. Trialing, don't want to leave the room unless you're satisfied with something. If something feels off, it usually is. It's not usually just, oh, this patient's anatomy is weird. Get an x-ray and a good one if you're not sure, and then always remembering that combined version, and then execute your plan to get the perfect case. So we're at an hour and 15 minutes, so I'm going to kind of go through AVN and DDH just over the next 15 minutes, and then we'll be done, okay? So we showed that one x-ray. This is that same x-ray from the very beginning at the pelvis showing a case of AVN. This is over the course of 4 months. So this patient came in first with this x-ray like this, got an MRI, showed an AVN lesion, collapsed within 4 months. So this can be a pretty bad disease. I'll just skip this. Actually, we'll talk about this. So this is a patient with leukemia who had steroids. Got a CT scan for another reason, was found to have this small lesion on the left hip. Subsequently got an MRI, had lesions on both sides. And so the question is what maybe to do for it. AVN, osteonecrosis, it's a loss of blood supply to the head. Usually younger patients is about 10% of total hips. Monica, if you're doing a total hip for someone with AVN, what's the one thing you tell them that are at higher risk for, besides where?
Instability?
Yeah, good. Instability. Yeah, perfect. Instability. And why?
I think because, you tend to get so in AVN, you get flattening of the femoral head and can collapse. And so I think it has to do with the abductor stability, if I'm remembering correctly.
No, not quite. Will, do you know? Why is AVN more likely to have problems with instability than an OA case?
I'm not sure.
Freshman?
I'm also not sure.
People with AVN tend to progress very rapidly, so their soft tissue doesn't contract like a arthritic hip.
Yeah, perfect. Yeah, people with AVN generally are younger, so they're going to be more active. They're generally advance quickly, like this patient. So this patient went from a totally normal hip to a collapsed hip within 4 months. And so they don't have time to adapt to the same capsular amount. Like the capsule doesn't have time to adapt to the same amount as an osteoarthritic hip is. They don't get the same contractures, and they're much used to a higher range of motion from the onset. So for a lot of those reasons, they're similar to fracture patients, right? So femoral neck fractures have the same risk of dislocation or the same increased risk as an AVN patient, because again, it's an acute event that has happened. Their capsule's not tight, they're not scarred, they're not used to being stiff in the first place, and so they're at a much higher rate of getting dislocations. Okay, let's go through this. So you can get traumatic or non-traumatic. A lot of different reasons that you can get AVN, but they all kind of come down to some sort of pathway that's causing blood flow disruption. Corticosteroids are probably the most common reason. Alcohol, HIV, hemoglobinopathies, and then idiopathic is not listed here, but that's probably a big chunk of these as well, is that some patients just get it and we don't know why they got it. They don't meet any of these categories, but they get it regardless. The traumatic pathway we think happens from some sort of blood flow disruption causing ischemia. The other pathways all come from some sort of, they think, clots to the critical part of the head. Roddy, what's the major blood supply to the femoral head? Track it from the external iliac.
So from the external iliac, it turns into the femoral artery, and then coming off the deep femoral artery, you get the medial femoral circumflex, which courses up behind the femur, like turns into eventually the lateral epiphyseal artery, and there's all these like little retinacular vessels that go into the capsule and also contribute to the femoral head blood supply.
Good. And so where is that medial femoral circumflex located usually? Or where if you're looking at a hip, front, back, top, bottom?
Posteriorly.
Yeah, posterior and kind of a little bit inferior. Okay, good. What happens is the bone is dead, right? It's dying. That's the main.
Quick question about blood supply. Is it reliable? I thought I remembered learning that the artery comes basically just proximal to the quadratus femoris, so that's why you want to avoid taking that down.
Yeah, usually it's kind of in the quadratus femoris. So if you most approaches for someone who's saving a head, you are not going to be going through the posterior capsule in any way, shape, or form. Okay, so you're either going to do some sort of surgical hip dislocation where you're actually going through the front, even though it's a posterior approach in terms of the capsule, or you're going to try and stay out of that back short external rotators of the hip. But yeah, you're correct in that it is usually kind of in those distal short external rotators, kind of in that region. Does that answer your question, sort of?
Yeah.
Like if you're doing a hip washout. So for example, hip washout, don't do a posterior approach, right? You should be doing from the front. You should be doing an anterior approach for a hip washout. Otherwise, they're going to get AVN. They may not get it in the first year, but they're going to get it at some point. Risk of AVN can go out to 2 years after a trauma or 2 years after some sort of insult.
Cool.
The Foucault staging is probably the most commonly used one that you should know. You don't need to know these kind of varied differentials. Now, Foucault is based on X-rays, not on MRI. So stage 1 is a normal plain film X-ray. Usually you can only see it on MRI. Stage 2, you start seeing sclerotic or cystic spots in the bone on X-ray. Stage 3 is where you start seeing what's called a crescent sign or early evidence of subchondral bone collapse. The actual articular surface may still be okay, but if you see that crescent sign, it's going to collapse. And then stage 4 is where you've had actual joint collapse, Stage kind of 5 isn't in the initial classification, but stage kind of 5 is where you start getting acetabular changes also. These are just kind of that more differentiated. But stage 2 on plain film, you kind of get those little cystic bubbles. Stage 3, you start seeing that line. Stage 4 is where you start getting collapse. So things that you want to know when you're evaluating an X-ray for an AVN patient: are they pre or post collapse? That's really important for prognosis. If they've collapsed already, pretty much the die has been cast. If they have not collapsed, there's still a chance for treatment, preservation treatments. One angle that's often tested is this Kerbol angle, which is the sum of the extent of the degrees of the joint surface that's affected by the lesion. So if this lesion is marked out by this line, you add up the AP and the lateral view, the total degrees, and above 200 is less likely to do well with any sort of bone-sparing surgeries like decompressions or things of that nature. It also matters where these lesions are. So if they're in the weight-bearing dome, even less than 200 is often poorly prognostic. If there's any acetabular involvement, you're pretty much, cat's already out of the bag. In terms of asymptomatic hips, so first off, non-op treatment for these. They used to just tell people to be restricted weight bearing. Doesn't work. Doesn't make any difference to the natural history. They're still going to progress at the same length or same rate. If you look at patients who have these found incidentally, which is actually not uncommon, the ones that are more likely to advance are the ones that are bigger, the higher angles, and the bigger percentage of the femoral head. Okay. In terms of intervention, all these non-operative interventions are kind of still sketchy at best. There was this one study that came out about 10 years ago, 12 years ago maybe, looking at bisphosphonates for osteonecrosis. Was really promising. All the patients that got bisphosphonates didn't progress to collapse. It's since been redone in a couple of other studies, and there's not really ever been shown a difference anywhere close to this one. So bisphosphonates are kind of a plus minus. Sometimes we'll do it if we're just trying to give them something and they're already osteoporotic anyway, but for the most part, these are not effective. Core decompression is very good or is an option for grade 1, stage 1 and 2, not an option as soon as that subchondral collapse. Okay. So if they get into stage 3 where you start seeing that crescent sign, not going to be as effective. Also bigger lesions, so those ones with the high Kerbol angle, not going to be as effective. There's tons of studies about kind of how to do this, injecting stem cell afterwards, putting vascularized fibula in there afterwards, putting bone graft in there. The results are all kind of all over the place. In general, it's kind of not a home run by any means.
How does that work exactly? I mean, if the vascular supply has gone, I don't really quite understand how decompressing it is going to revascularize the head.
Yeah, the idea. I don't really know. The idea is that if you're putting a big hole in the marrow bone and kind of carving out that sclerotic end, the plate, kind of the bottom of the lesion is usually very sclerotic and kind of dead bone. That the idea is that blood vessels can't get back through it. So if you break up that kind of sclerotic rim, they think that blood flow can start getting back into it. But I don't know. I don't know the answer to you. I'd be making shit up other than that.
Have you ever used in your practice, Jeff, done a core decompression?
No. So the way we have it here is that Zhang does most of the core decompression. So the hip arthroscopist in the group does most of the core decompressions. But we in arthroplasty, none of us do, and we usually just send them to Zhang.
Got it.
And then we take them back when they inevitably fail. So just kind of as a side note, these are the vascularized bone grafts. There's the founder studies, whoever does these, they have really good results. And then usually when they get tried to be done by other people, the results kind of go down. In Asia, they do a lot of these kind of rotational osteotomies and things to try and offload the area that's got the lesion with varying success. It's just going to make your arthroplasty more difficult later. Everything in AVN has kind of goes in circles in terms of different treatments. And I think a lot of it has to do with that the end game, a total hip, does very well. And so even in young patients, 30, 40-year-olds, the outcomes for total hips are so good that it's hard to beat them with almost any sort of preservation procedure that's not getting 80+% success. And even the ones that are quote unquote successful, most of the studies only go out to 2 years. If you go out farther, they eventually progress to a total hip anyway. So as a joint surgeon, our preference is definitely to do things that are not going to make the joint replacement more difficult. So things like fibular struts or osteotomies with plates, that's going to make the joint replacement more difficult. So would kind of caution against that if someone was asking me what to do. Core decompression doesn't really change what you do. Pretty low risk. Bisphosphonates, low risk. But you can see kind of all these academy guidelines in terms of what is or without recommendation and evidence. It's like insufficient evidence for pretty much everything. Decompressions in early stage disease have good evidence that they work. Osteotomies, bone grafts, stem cells, kind of all that is kind of wishy-washy. Okay, great. And then there's recommendations against restricting weight bearing. So this guy ended up getting core decompressions on both sides. This is one of Hansen's patients. Ended up getting core decompressions on both sides. Left side didn't give any pain relief, so he got a hip replacement. Right side is now 5 years out and has collapsed. So he's probably going to be getting a hip replacement soon on that side too. Okay, so really briefly on DDH. Adult developmental dysplasia of the hip. The Crow classification is one that you guys should know, as is the Hartophilochetus. I'm just going to kind of flow through this. So this is the Hartophilochetus one. Basically, it's low dislocation, kind of a double bubble or a full all the way out for the Hartophilochetus. And then for the Crow, it's the amount of migration of the head up the acetabulum. So head's 50% out, 50, 75% out, 100% out, or more than 100% out is the easiest way to think about it. Really, it's 1, then 2 3s together, then 4s. Those are kind of the treatment differentiations. What else? So shallow acetabulum, usually anteverted, usually anterior and superiorly deficient. The femoral head and the femoral shape is also different because this is a developmental problem that often there's excessive aneversion and a valgus neck. The greater troch is often farther posterior than normal, and the femoral canals are often very narrow. Like we talked about for the joint reactive force diagrams, it's kind of the double, it's 2 strikes against them. It's a valgus neck, so they have less of an abductor pull, and it's a lateralized hip, so they have more body weight. Both those things, as well as kind of edge loading and poor head to acetabulum contact, lead to pretty early joint wear. These angles are more for the peds guys. We don't really use these angles as much in arthroplasty, peds or for preservation type procedures, but tonus angle, lateral center edge angle, and anterior center edge angle. That's more for if you're doing preservation type work. So an example would be this patient, 32, getting some groin pain, still has some joint space, low tonus grade. An option for them would be sort of a preservation type procedure like a PAO. So see those with the, not going to talk about that too much. Whereas older patients failed non-operative management with DDH, then arthroplasty becomes more of an option. This is the true kind of Crow classification. Kind of, you can do these crazy calculations. No one actually does that in practice. They would just call this a 2-3, probably a 2. And then these are the progressing things. So if you look at the right hips here, Crow 1, slightly high, slightly undercovered. Crow 2, 50 to 75% of the way out, high. Crow 3, 75 to 100% of the way out, high. Crow 4, all the way Same deal with the heart affiliatus. In terms of treatment options, so freshman, this patient comes in, imagine they actually had arthritis. What, for the left hip, what are some different things you got to consider when you're doing their hip replacement?
Yeah, I think what we were talking about before with the proximal femoral anatomy is going to be the biggest thing. So first, well, that and then just other things we'll talk about more stuff. But the first thing is that they have that really high neck shaft angle. They're very valgus, and so knowing that when you do eventually put in your stem, that you're if you put in a high offset stem, you can be really increasing their offset. And second, their anaversion, you kind of also need to take that into account. Third is if they've migrated proximally, you're going to have some difficulty.
You don't need to get into that stuff for this one, but
okay.
So yeah, you're absolutely right. So just being aware of the version. What about for the socket? Are you going to use a regular socket for something like this, a Crow one?
For a Crow one, I think you can get away with using a regular socket because you don't have a lot of deficiency in your acetabulum. You don't have like that pseudo acetabulum that's formed as much as like a Crow 2 or 3.
Yeah, exactly. So Crow 1, usually you're just going to get away with a regular socket, uncemented socket. Generally not going to need any sort of special augments or anything like that for Crow 1. Even the femurs are usually pretty mild, so you can normally get away with a regular implant. Now, Crow 2s and 3s, like this patient, Tiffany, so we've talked about this a little bit. What are some challenges now for this patient that's a little more extreme? This is kind of a Crow 2-3 heart affiliacitis 2 or B.
Yeah, so you have more proximal displacement in this case. So I think putting the acetabulum in a good position is going to be more challenging. And you may need, like augments or something to help you, or like graft or something to make sure that your cup, you can put your cup in a good position.
Yeah, exactly. You're going to move that hip center down, and then the extreme nature of the anaversion may throw you off.
Mm-hmm.
Well, like some people will look at this cross table lateral and be like, "Oh wow, that's really anaverted." Don't call inversion off of a cross table lateral or frog lateral. Okay, way too rotation dependent. But yeah, they're going to have a lot of weird anaversion, so you need stems that are going to be able to adjust for that. So these are kind of the
How do you manage the capsule in that case like that? Are they super loose in the posterior capsule or anterior capsule?
What do you mean?
Like in AVN, we talked about younger patients are at higher risk of dislocations because they don't have a scarred down capsule. I'd imagine this patient's capsule is kind of jacked up. How does that affect your soft tissue balancing and intraoperatively?
Yeah, good question. It's more of we'll talk about that a little bit more with the high dislocations. The low dislocations, generally, you're not going to be like, you're going to keep their leg, you're going to try and lengthen their leg effectively, right? So by bringing this one back down, you're going to be lengthening their leg. Usually the muscle and all the soft tissues have been used to being so short that lengthening is going to take up for any kind of redundant capsule or anything like that. Okay. These people are at higher rate for dislocations for other reasons, mostly because you have to do such a big dissection to be able to get the cups in, and you're doing a lot of releases to be able to get them back down where they belong, less so because of capsular laxity like an AVN or a Femur. These are kind of the options that you do for a 2-3. Historically, you would use some sort of like the femoral head as a bone graft. No one does that anymore. Pretty much everyone would replace this augment with a metallic augment if they were doing this type of procedure. The other option is there's a lot of data, especially in the Asian literature, for leaving the cup high. You can get away with that a lot of times. It's a little bit disadvantageous for the abductor to remain short. It's a little worse bone up there, but you can get pretty good outcomes with leaving the cup pseudo high. And then the other option is to go medial and smaller and go distal. So you can just leave that uncovered part up top, go small, distal, and medial, purposely kind of protruding through the center to get more coverage. In general, you want less than 30% of that lateral lip uncovered, and about 2/3 of the component supported, but you can push that even less with revision components.
What did you guys usually do in fellowship with like Faring? Was he using augments or putting it high and break it down?
Yeah, generally trying to get the hip center back down is preferable. They'll leave it like maybe a centimeter up higher than normal, just putting in a shell that's going to fit in there. But anything more than a centimeter or two of vertical displacement, they're going to put an augment and bring it back down.
Okay.
This would be what, if you see these anywhere, this is what those bone grafts look like if you were to use a bone graft augment. High hip center, again, you know, you're going to have trouble getting their limbs equalized, possible for impingement, because you're closer up to the wing of the ilium. This would be what kind of like an augment would look like if you were bringing it down. This isn't a dysplasia, but the defect's going to be different, similar, trying to bring that center rotation back down. So this is Crow 4s. So some unique challenges with Crow 4s. So high dislocations. Abby, what are some things that might get you worried about doing this case? So say we wanted to, you know, the cup, I'll just give it to you. We're going to put the cup down lower, back where it belongs. What are then going to be some issues in doing this reconstruction?
Well, I think, you know, you're going to have a much bigger dissection to get everything exposed and bring that femur down. And then the bone quality and the bone stock down where we're trying to put the cup is decreased compared to, you know, the other milder classifications. So, you know, you're going to have some issues in getting a good fit there. I think you can do some of the similar things we talked about, but it's just going to be a lot harder.
What else? So if I reduce that hip in right now, say we templated this and I had my template dot up here and my cup dot down here, we're going to lengthen the hell out of it. What is the most that you'll lengthen somebody?
I think in one setting, I mean, 4 centimeters. I mean, you're going to start getting worried about nerve palsies and the soft tissue itself too, just to get a good stable hip.
Exactly. So what if this was a girdle stone patient? Say this is exactly what the x-ray looked like, but it was someone who I had surgically done a girdle stone. Would you say the same thing in terms of 4 centimeters is the most you'll shorten them? Or most that you'll shorten them?
So I think, I'm not sure, but I think, you know, with a girdle stone, their soft tissues may not be as tight as they haven't been ambulating on them. And so maybe you have more leeway, but I'm not sure.
Yeah, the difference, I guess I was just trying to get at is developmentally being short versus being put short. Okay, so if someone developed at their normal leg length, and then you cut them and they just shortened for a period of time, their nerves should theoretically be able to stretch back out to where they developed. This person developed up here. Their socket has never, or their femur has never seen that acetabulum. Their nerve long enough to go back down. So that's where that 4 centimeters comes from. And 4 centimeters would make a lot of people nervous. I would say most people are closer to 2.5 centimeters. I agree with you. There is literature out there saying 4 is safe, but most people, the max that they're going to lengthen somebody is 2 to 2.5. So Eric, what are they going to do during this case? Say this is a 6 centimeter gap. They put the socket down here. What's the options to get that femur back down and not lengthen them by 6 centimeters?
You can cut the femur.
Elaborate.
You can do a subtroch osteotomy to remove that amount of femur, so you're not lengthening quite so much.
Yeah, good. So you're going to take out a chunk of the femur so that you're still keeping the proximal anatomy for fixation and then bringing them back down. And so let me just skip all this stuff. But so you're going to shorten the femur so you can do the top part, pull traction on the leg to whatever is a normal tension. You can have preoperatively planned how much you expect this defect to be, and then reduce the rest of it back on there. You can even save that bone graft for around the osteotomy site, putting it back together. So for this patient, whoever did that same thing, shortening osteotomy. They did a little mini plate, which you don't need for a lot of implants. And then they did the same thing on the other side. Okay. Yeah, 2 to 4 centimeters is generally the acceptable lengthening. I'd be really careful about the 4 though. Okay, so say Abby, say you shorten them, you go to PACU, and they're in the PACU, they haven't had any blocks or anything like that, but their perineal nerve is out. What are you going to do?
So yeah, I think there's a couple of ways to think about it. I think one is if you were in the operating room, if you visualized obviously if you had anything like any injury to the nerve in the operating room, you would know. But you can kind of wait and see. There could be a hematoma that could be forming around the sciatic nerve. But I would try to relax the nerve and see if that goes away.
Yeah. Yeah, I think that's good. I guess the thing I'm getting at is if they wake up and they don't have any, say their sciatic nerve is entirely out, or their perineal is like densely out, and you just did a big case like that, you're probably going to take them back and shorten them further. Okay. If they're normal for a period of time and then it's kind of in and out, you can probably just watch it and wait. But if you've done a big case like this, you're probably going to take them back and shorten them further right off the bat. Okay. All right. We're gonna stop there. So this is another just shortening osteotomy. A lot of people use SROM type procedure, SROM type implants for these type of cases.
Jeff, do you use a nerve stimulator when you're on the borderline for these intra-op?
No, I haven't seen that done before. I know that's a described thing, but I've never done it. Some people will do like full-on neuromonitoring, like a spine case, and like drape out so you can hook on neuromonitoring leads and things. I haven't done that. Generally, if you're just kind of feeling the tension of the nerve, I mean, I haven't done a lot of these, obviously, but the people I train with would just kind of feel the tension of the nerve. You can feel when that thing's getting taut like a bowstring, and it's too tight. Okay, so these are just put on the back of this, the hip chapter, top testing facts. A lot of these are garbage, but whatever, it's in there. Yeah, any questions? I know that was a ton of shit. It's like half of all of arthroplasty in 2 hours, but any questions?
I had a question on, going back to the anteversion of the hip and the femur. So like, let's say you make your neck cut and you find that it's very retroverted, then you would then make your place your socket in a more anteverted position to make up for that, right?
You can, correct. Yeah. The other option is if, so that comes into more play, like say you're doing a dysplastic patient, you do the neck cut and you see that they're like 60 degrees anteverted, right? You don't, in those situations, you're not going to necessarily retrovert the socket. You're going to use some sort of an implant that's going to allow you to change the version of the neck. So standard implants like the ones that we all use for our primary hips, they're designed to go in the orientation of the femoral neck. So that proximal portion needs to be in line with the neck to get good fixation. So you shouldn't be, you can't really change the version of most of those stems more than 5-10 degrees from what the native is. So if you need to get closer to the 10-15 degrees of anteversion in someone whose native is way off, you have to use an implant that allows you to do that in different ways. So those are like either the modular implants or the ones that are purely diaphyseal fixation, and things like that. But if you go in and your native version is kind of neutral instead of the 10 degrees, you can still put that femur in at neutral and just add a little bit of acetabular version. You can't, it's all kind of a little bit of changes. You can't make up 30-40 degrees of version deformity. Does that make sense?
Yeah, thanks.
Anything else? Cool, guys. I know this is a lot of arthroplasty for the morning. Maybe we'll talk to Hanson and Ward and see if we still want to do the noon case conference or not. I don't know. Quasi, are you still on?
Yeah, I'm still on. What would have been your workflow for the like Crow 4 one?
Like any of these?
Yeah.
So this one was mine, but the so workflow is usually do the so get exposure, which is sometimes hard. Perform the socket. So you get the socket in. Then typically you'll prep without having done an osteotomy. You prep for an implant. So you prep for your SROM, get the whole SROM in, and have prepped an extra, 2 centimeters or however far down you think you're gonna have to shorten it. Then do the osteotomy, put the implant in the proximal body and reduce the hip. So you have the hip reduced with the proximal body and this whole implant in, and then the shaft is just separate, right? Pull traction on the shaft of the femur and try to get them to overlap and see how much that overlap is. Mark it, cut the distal femur to make it reducible, and then put the whole implant together again and reduce it into the hip.
Okay, cool.
Kwesi, do you want to do cases at noon, or what do you want to do?
I mean, I got nothing else to do. then clinic with Hanson. So
Dr. Barry, so you're saying that osteotomy then is distal to your stem if you're having put your implant in? It's not sticking out, or is it sticking out the bottom of your femur at that point?
Correct. Yeah, so this implant, all these implants, there's like tons of data on. So this SROM is a little bit of a more higher level thing. Maybe we'll do a DDH case at noon if you want, Kwesi. But yeah, a little bit, these implants have splines on them. So you can see in this bottom right corner how the splines are pinched together.
Yeah, for rotation.
So there's also like grooves all the way down. So there's no fixation in this distal part of this femur except for those splines. So the on-growth surface is up here, and then the only way you're fixing this osteotomy is with the splines, which is a very, it has a really good tracker. You'd think that it would just spin around this distal part, but nothing's in there except for that squeezed together spline.
So how do you get that distal fragment reduced onto the spline sticking out from below?
Gotcha. Yeah. You take everything back out, right? So take everything back out, put them together, then reduce the hip back in.
I see. Okay.
Good question. Usually you'll do that first cut with trials. You won't do it with the real implanting.
Any tricks on holding your osteotomy pieces in while you put that cable around, or is it just a little futzy?
Oh, those little osteotomy pieces, it's just futzy. That's kind of shit. I don't even know if that does anything. It's a described thing. That guy's 6 months out. He's already healed. Or he's a year out now, but that X-ray was 6 months out. He's already healed. You can kind of see this one is the different way to do that. They just threw out that osteotomy piece. I think this was Hanson. He did like a little mini plate to kind of back it up. This is a similar stem to that, or it's not the same as the SROM. This is a spline stem, so you're getting some fixation from spline or from taper. Yeah, it's a fluted stem, so there are sharp spines all the way down. So it's getting fixation distal to the osteotomy here with the spines on both sides. This is a fully coated implant, so it's getting just a scratch fit down below and above. So a bunch of different ways for how to fix these. Most people, the most technique is either this SROM or something like this, the fully coated stem on the left. All right. Good deal, guys.
Thanks, Wade.
Thanks, Dr. Barry.
I'll see you at noon, Kwesi, or whoever wants to talk about cases or something.